With that, I would like to now introduce our keynote speaker, who I was delighted to succeed in convincing to come and speak to us. Zulfi Bhutta is a professor and the founding chair of the Division of Women and Child Health at Aga Khan University in Karachi, Pakistan. He also holds adjunct professorships in international health and family and community medicine at the Departments of International Health at the Boston University and Tufts University, respectively. He was designated as a Distinguished National Professor of the Government of Pakistan in 2007. He is also the Dean of the Faculty of Pediatrics on the College of Physicians and Surgeons and the Chairman of the National Research Ethics Committee of the Government of Pakistan. I'm going to abbreviate his introduction so that I leave him some time to speak. If I went through everything, we would clearly run out of time. But briefly, he's published 4 books, 55 book chapters, and over 320 index publications to date. His research interests include newborn and child survival, maternal and child undernutrition, and micronutrient deficiencies. He leads a large research group based in Pakistan with a special interest in research synthesis, scaling up of evidence-based interventions in community settings, and health systems research. Please join me in welcoming Dr. Bhutta, and please turn off your cell phones. Thank you.
So good evening, and thank you very much for that generous introduction, and also for the invitation to be with you amongst today. I must confess that I think it's a pretty brave thing to do, to ask someone who works in public health to join a conference such as this that I've heard a lot about, but it's principally a conference of pediatricians. But I'm delighted to be here amongst you as a fellow pediatrician. And what I will share with you over the next 30 minutes or so is the context to where the globe stands in some of the priorities in relation to newborn and perinatal survival. And how can we, as a community of pediatricians, irrespective of where we are, which institutions we belong to, make a difference? So what I hope to cover is some of the context of the Millennium Development Goals and the challenges that we have in terms of achieving them. I'll talk a little bit about determinants, particularly of mortality. I will cover solutions, but principally cover some of the exciting emerging innovations in relation to those that can impact mortality where it's clustered, and hopefully finish with some challenges in terms of what we can do together. So, ladies and gentlemen, to those of you who are unaware of the Millennium Goals, these were principally cast by the global community of nations as targets to address an integrated framework of health, nutrition, education, and development. Of these, the goals that particularly pertain to the subject in question tonight are the goals that relate to child mortality, Goal 4, which calls for a 2/3 reduction in child mortality from 1990 figures by 2015, within the next 3 years. And for maternal mortality, Goal 5, which calls for a 3/4 reduction in maternal mortality from the base figures of 1990 by the same figures. Now, these goals are largely about numbers. And what I hope to cover with you tonight is the fact that in order to really make a difference, we've got to understand not only what we know in terms of the numbers, but what we don't know. And it was Einstein who actually said, not everything that can be counted counts, and not everything that counts can be counted. So what is it that we can count? So we can count deaths. And as we speak, of the close to 300,000 maternal deaths worldwide, they're largely clustered in the continents of sub-Saharan Africa, South and Central Asia. The confidence bounds around these numbers range from about 250 to about 400,000 maternal deaths. If I was to superimpose on this map a map of child mortality, you will find that it's the very regions which have the high clustering of maternal mortality that also have the highest number of child deaths. So we are dealing with close to around 7.5 million children under 5 who die every year in these parts of the world. We have, however, made progress. In these recent estimates, we have looked at how mortality has gone down over the last 2.5 decades And yes, we have gone down from the extremes of mortality that were witnessed and for which records were available in the 1990 base. And particularly for child mortality, the average reduction has been around 2.5% annually. But you will notice that in this very slide, the rate of decline for early neonatal mortality, in contrast to late neonatal mortality, is much slower. And therefore, you can begin to see the divergence of these lines, with largely the residual mortality being clustered around newborn deaths. And I'll try and make that a little clearer in terms of saying how important it is to tackle newborn mortality if we were to achieve child survival goals. So this map will show you where are countries located which have not made a lot of progress in reducing newborn mortality. And you will notice it is the very countries which have had high rates of child mortality and maternal mortality where the relative rate of reduction of newborn mortality has been the slowest, largely in sub-Saharan Africa, South and Central Asia. So as we speak, if we were to look at numbers, and you were to look at the top 10 countries which have the highest burden of newborn deaths, these are the countries which have 2/3 of the global burden of newborn mortality. If I was to scramble the same countries and see what is the proportion of maternal deaths in these very countries, you will find that close to around 340 maternal deaths are concentrated in these very countries, representing again 2/3 of the global burden. And another area that none of us talk about, neither pediatricians nor obstetricians, is the unknown, unrecognized, and uncounted burden of stillbirths, of which these very countries have about 2/3 of the global burden. A large proportion of these are intrapartum deaths, fresh stillbirths, which are an extension of newborn mortality. So as we speak, ladies and gentlemen, I've given you these numbers. The fact is that in 2011, at the end of 2011, barely 3 years away from the Millennium Goal targets of 2015, almost 3/4 of the 68 countries with the highest burden of maternal and child mortality are not on track to reach these targets. And that's the challenge for all of us, to accelerate progress so that this huge public health tragedy of unnecessary mortality can be averted. Let me now turn for a moment beyond the numbers to talk a little bit about causes. What is it that we know about what kills these newborn infants that can be amenable to interventions? And let's start with the mothers. So of the maternal deaths globally, 4 disorders that you see highlighted on this slide, hemorrhage, hypertension, preeclampsia, sepsis, and obstructed labor, are responsible for about 60% of maternal deaths. If you were to turn to newborn deaths, 3 disorders, prematurity, asphyxia, and infections, are responsible for close to around 80% of all neonatal deaths. And there is a very close relationship between the two. For the maternal causes that you see out there contribute to almost 2/3 of the burden of newborn deaths that you see on the left side of this particular slide. So there is a very close link between maternal and newborn morbidity as well as mortality. And therefore, in addressing this, pediatricians have to start wearing a hat which also looks at maternal health and maternal interventions. To give you just one stark example as my final number, just look at the period of delivery, the time of birth, as just one event in time. If you were to take that and count how many deaths occurred just at the time of birth, these are 2 million deaths, counting maternal deaths, stillbirths, and neonatal deaths. And that's the importance of targeting, because as you will see, this is also the time period where our coverage and our access to care is at its lowest. So these, ladies and gentlemen, are facts. And as you can see, facts sometimes don't tell you the whole story. So in order to understand where we need to go, you have to kind of go beyond the obvious causes. So let's look for a moment at the determinants of mortality. And I don't have time to delve into this in detail, but I'll just cover one or two aspects that are critical to understanding what to make a difference for maternal and perinatal outcomes. So we talk about poverty. And a global understanding of poverty is that it's really income or assets that determine whether or not people have access to care, or mortality clusters amongst the poorest on the basis of socioeconomic indicators. And there is no question that poverty matters. Poverty is critically important to break barriers which relate to both access to care and also provision of services. But you have to recognize several dimensions of poverty. And one of the dimensions that I want to introduce, because it's critical to our action, is the whole issue of inequity. Now, many people don't understand the difference between inequality and inequity. Inequality is the reality of life. It's the difference between people, individuals, social classes, the rich and the poor, and to a certain extent, it is human nature, and it's there. Inequity is when you have an unjust inequality or an unfair inequality. So in the context of child survival, this slide summarizes some of our work looking at the coverage of some of the key interventions in some of the best countries of the developing world. So if you take these countries, which have done very well in general in providing services for child survival, and you look at this band as the difference in coverage between the richest, which is on the extreme right, and the poorest, which is reflected by the left, you will find that these differences in some of these countries are of twofold, threefold magnitude. And the point to drive home is that in order to understand poverty, you have to understand inequity, because it relates to the way we target some of our interventions to those who need it most. Mother Teresa defined it perfectly, because she said, the real poverty is not poverty of means, is not the poverty of being naked, hungry, or homeless. It's the poverty of being unwanted, unloved, and uncared for. Why am I sharing this with you? Because in the context of maternal survival, some of these concepts or dimensions of the lives of poor people, and particularly poor women, are absolutely critical to our interventions. Let me illustrate that by just one example. Now, this is my own country, Pakistan, not a desperately poor country, but has huge inequities. Now, if you see some of the inequities between the richest and the poorest in our analysis of a DHS data of how many pregnancies are protected by tetanus toxoid and how many deliveries take place in facilities, you can see the difference between the haves, the richest quintiles, and the poorest. Now, if I were to superimpose on this slide two additional dimensions that people generally do not capture, and these two additional dimensions are how many of these families had actually bothered to discuss the place of birth or make financial arrangements for childbirth, you will find that in the poorest parts of the population, on the left, less than a third of these families had even bothered to discuss something as fundamentally important as the place of birth. This is the sense of fatalism that one has to address in trying to tackle perinatal and neonatal mortality. And it is one of the major reasons why we encounter so many barriers in trying to do this by advocacy alone. So if you were to take South Asia, including my own country, as an example where you have health systems that exist, that you have village health services at the base, that you have referral hospitals and district hospitals, the quality of care and access to services is such an issue at the basic village level that when people are confronted with this problem affecting mothers and newborns, they typically vote with their feet. So what do? They either try and seek care at the upper end of the health system, or they stay where they are. And that's one of the reasons why, when you look at mortality distribution for newborn deaths, you have a fairly universal story in many parts of the developing world, with about 50 to 60% of deaths taking place at home, either not seen or seen but not managed properly. About a third make their way to hospitals, and about 5 to 10% die while seeking care. Now, why am I telling you this? I'm telling you this principally because unless you have an understanding of where the problem is, you could be shining all the light and all the efforts within facilities and at the upper end of the health system and not tackle where the problem clusters specifically. So let me now quickly move on to solutions, because I don't want to give you a doom and gloom scenario. But the context was important for me to build the case as to why some of us have been working particularly on trying to address the problem where it happens. So many years ago, we looked at, because of the clustering of newborn mortality, the whole range of community-based interventions in terms of addressing perinatal outcomes, and we did a systematic review of what existed in terms of information and interventions in depth. We were subsequently able to put all of that together and identify from those 40-plus interventions, 16 key interventions that were critical to newborn survival and could be delivered across a range of settings to save newborn lives. We published that in the Lancet as an advocacy document, which then led to a significant global policy change in terms of what could be done. We said that these interventions were cost-effective. They were not expensive. They were not rocket science. And a lot of these interventions involved maternal care and therefore would have a double benefit of also impacting on maternal health outcomes. These interventions focused on the major killers, both in terms of prevention and reducing the risk of adverse outcomes from those major killers. What we also said was that these interventions could be packaged in the very health system where I've just shown you the clustering of mortality at the base. One could develop family and community packages for appropriate delivery through the right vehicle. You could have outreach services through fixed outposts, and you could have clinical or facility-based care. We also modeled and estimated that if you were able to deliver these interventions at these very levels of the health system in the way that I've just described to you, that we could impact change. And our model indicated that we could reduce overall neonatal mortality by impacting these at the very level that they occurred between 40 to 60%. If you delivered the entire package, you could reduce 60% of newborn deaths. And if you were able to deliver just the community-based packages, you could theoretically reduce about a third of all newborn deaths. This was about 8-9 years ago. And as people know, unfortunately, research reports are the last things that change policy. It is action and implementation that makes a difference. And where we failed in the ensuing few years is to deliver and implement some of these interventions at scale. So, for example, this is the global coverage of some of the interventions that I've just talked to you about. And if you see this global coverage data reflected as percentage coverage of interventions in the countries with 98% of the global burden of mortality, you'll find that people move in and out of care. It's a little bit like a yo-yo. Where we do reasonably well are interventions that can be delivered through vertical programs. And where we do absolutely terribly are around skilled birth attendants at birth, postnatal care, and newborn care. There is also an issue of the differences in coverage of the rich and poor, as I talked about, the inequity dimension. And you will find that the widest inequities that we have are around maternal and newborn care, with the gaps being much wider than what you see from vertical services that can be delivered through fixed outposts. So it was very clear that just by publishing advocacy, producing documents, we would not be able to affect change. And something much more tangible and logical would be needed. So that's what I'm going to spend a few minutes about by talking about innovations that can help us take these interventions to where it matters. So I'll talk about a few innovations. The first innovation is to break financial barriers. And one of the largest experiments has been undertaken in India, where through a cash transfer program called JSY program, families have been given an incentive to go and deliver in facilities. So this conditional cash transfer program is largely to break the financial barrier to access care in the lower end of the health system in secondary care facilities and where safe childbirth can be done. This is not a small program. It's a large program spread over various states, but it's not a hugely expensive program in the context of the population that you want to cover. The allocation in 2009 and 10 for this program was only $340 million. The coverage of this intervention has specifically targeted states in India where skilled care and facility-based deliveries are poor. So you will notice that in the north, in particular in areas where facility-based births were poor, the uptake of this intervention was the greatest. But there is a large variation between states. So some states have had a lot of people receiving this intervention and uptaking this, and others have had lower. When this program was evaluated about 2 years ago, in terms of what difference had just breaking this financial barrier done to perinatal survival, the results were striking. In this analysis by Chris Murray and his colleagues from Seattle, they looked at perinatal mortality and stillbirths. And as you can see, overall, close to a 25% reduction in stillbirths and perinatal mortality through the introduction of this program. So a huge advance. The second innovation pertains to going beyond just the financial barriers to service delivery through alternative cadres of care providers, community health workers, using approaches like support groups and approaches like community-based counseling for women and young adolescent girls. The first effectiveness trial of this was done in my own country and published earlier on this year in the Lancet that I just want to share with you briefly. In this cluster randomized trial, in about 500,000 population, using government health workers, working in tandem with physicians, but reaching out to communities and households, two approaches were used. One was the creation of a community support group of men, and the other, the introduction of women's groups where counseling by community health workers could be provided for preventive and promotive newborn care in these settings. The results of this effectiveness trial done through a government health system were striking. We were able to see close to a 20% reduction in neonatal mortality. And we also witnessed something that we hadn't anticipated, which was a reduction in stillbirths. Now, we had not put a single obstetrician or opened a new facility in this area, so it was not very clear why stillbirths should have gone down until the penny dropped that we had been able to induce, through the use of community health workers working with the health system, a pretty significant behavior change in terms of the usage of facilities in these very communities. So you can see the trends in facility births in these districts, and I don't have to run any statistical analysis of this to tell you that this was significant. Now, life has moved on, and we are not the only group who have done these community interventions using alternative health workers. There is a large body of evidence, much of it generated by my group. There's a WHO report on the global experience of community health workers, and at least 2 systematic reviews, including a Cochrane review by my group, looking at what is the impact of using community support strategies and community health workers for reducing perinatal mortality. And I'll try and summarize this in a couple of slides. So the first point to take home is that these community intervention packages, using community health workers, almost universally reduce newborn deaths. This large body of experience now, over the last 10 years, very convincingly shows that you can reduce neonatal mortality by about a third. What we are also able to see is that in studies where data have been captured, they have a benefit in the right direction on maternal morbidity as well. So there are benefits that derive from the entire continuum of maternal and newborn outcomes. And there is a significant, close to 25% reduction in significant maternal morbidity, a combination of factors. What we are also able to see, what I just showed you from our large effectiveness trial, is that there is an improvement using these community interventions in care seeking for complications in facilities. And that in a hard outcome like institutional deliveries, overall, we have about a 28% increase in institutional deliveries using these interventions. So the point that I'm trying to drive home is that this innovation has now shown us how healthcare professionals can work with alternative care providers, not as task shifting and responsibility shifting, but as a partnership in terms of reaching those who are the hardest to reach. And that's the message that pediatricians worldwide need to take home in terms of the spirit of partnership in reaching those who are otherwise not being reached by current health systems. I want to talk very briefly about the third innovation, which is the role of technology. Now, many of us are under the misperception that technology in perinatal care has to be complex, has to be e-health, has to use cell phones or handheld PDAs, and things that require a lot of investment. But innovations can be a whole range. And the innovation that I'm talking about is something very simple that can be delivered to improve the care of the newborn baby's umbilicus after birth, delivered through clean delivery kits. Many of you may not know, but a major risk factor for neonatal sepsis in developing countries are unhygienic conditions in the environment and the fact that many of them develop cord infections with sepsis and very high case fatality rates. The WHO recommendation, largely based on work in the developed world, is for dry cord care. And that may not necessarily reflect the reality of working in the developing world, where people will apply all kinds of things to the umbilical cord. So we undertook a cluster randomized trial in rural Pakistan, which is just about to be published in the Lancet, where we have looked at cord infections and neonatal mortality. And the bottom line from this large study is that there has been a significant reduction just by using simple chlorhexidine being made available in clean delivery kits on reduction in cord infections and consequent neonatal mortality. And we are not alone. Similar findings have been reported from other parts of Asia, notably Nepal and Bangladesh. And this pooled analysis from these three large community-based trials now very convincingly show that this simple innovation of improving cord care in community settings, in distant populations, can reduce neonatal mortality to a significant extent. And this will potentially change global policy in terms of how you provide this care at birth. Towards the end, I want to highlight areas where we have failed. And although this is a meeting of pediatricians, I want to highlight two orphan areas. And the first one is the extreme importance of family planning to maternal and newborn outcomes. Family planning is widely regarded as important as immunization for children for maternal health. Yet, ladies and gentlemen, as we speak, this is globally now an orphan area. Why is this an orphan area? It's an orphan area because politics have taken away the funding from family planning. This slide shows you how we have failed as a global community of professionals to provide the basic funding for access to family planning for families in need. And that's a sad story of a collective failure of a public health community to provide a very specific intervention that impacts on survival. The other orphan area, which is critically important for both maternal and newborn outcomes, is maternal nutrition. Now, I will not speak too much about this because I know my friend Stan Slotkin will close your conference by talking about micronutrient deficiencies. But I want to narrate this story to you. This is a woman that I encountered about 6 months ago in rural Pakistan on a mission during the floods. And I was called to see this newborn baby on the floor of this hospital who was thought to have infections. You can probably just about see the cannula in his arm. As I looked at the baby, I saw the mother. This mother had walked 11 kilometers with this sick baby to seek care. And nobody had bothered to look at the mother. She looked as pale as death. You can probably just about see her pallor. She turned out to have a hemoglobin of 5, and she had a fever of 104. And what I'm trying to point out is that maternal health is frequently ignored in the entire dyad of maternal and baby care. Let me give you one example from just a week ago. These are data from the National Nutrition Survey that we've just concluded in all the provinces of Pakistan. And what you see at the bottom are women with a body mass index of less than 18.5, wasted women. And that's just a microcosm. This is just a reflection of one country with the number of wasted women who would then have a low birth weight baby, adverse outcome, and so on and so forth. Now, there is an intervention that impacts on low BMI and improved maternal and newborn outcomes, and that is balanced energy protein supplementation for women who are wasted. If you look at this particular meta-analysis done by us, you will see that there is a pretty significant reduction in low birth weight by this intervention. But I want you to see something else. I want you to see these years. And I want you to see that the last study done in terms of addressing this fundamental issue of maternal nutrition was in 1995, published in 1997. And since that period, there has been not a single project scaling up an evidence-based intervention globally. So maternal nutrition is another orphan area where pediatricians need to advocate for synergies in terms of addressing maternal outcomes. So I want to finish by addressing the question that we started with. How can we contribute to change as a global community of activists, public health professionals, and pediatricians? The first point to drive home is that business as usual will not get us to the MDGs. We are now 3 years away, and we are not going to get there. Does that mean that the MDGs are finished or that the quest to achieving those targets are finished? The answer is no. We need to continue to do better and to see that the focus remains on achieving those child survival goals. It is critically important to roll out the right things. We must do the right things by promoting evidence-based interventions at scale, ensuring that we are able to implement them through delivery strategies where they are needed most. And that also means that we must do things the right way. So that also means that the delivery strategies should be appropriate to the challenge of reaching the poorest of the poor. So this requires community engagement, outreach, promoting partnerships, and importantly, working with women to reduce the sense of fatalism around maternal and perinatal care. We can't do it alone. People like myself, who work in public health, deliberately by choice, need the partnerships that we have through healthcare professional associations. So your institute, Mr. Chairman, of Excellence in Pediatrics, would be a great opportunity to advocate for issues that are otherwise largely devoted to corners of schools of public health. We must focus on incremental gains. Sometimes there is a desire to do the ideal, the best, the most expensive, the greatest technology. I think we should go for incremental gains. What can we build on what we have? And what can we do steadily over time to make a difference? Advocacy is critical. You can get nowhere without getting into the conscience of people, be those your local politicians, be those your university deans, and be those your students. What we need for global maternal, newborn, and child survival is young people, is people who will devote the next several decades in achieving global equity. It will take several things to get there. It will take the political will. It will take proactive policies that we can implement, that we can practice, get to scale. It will take partnerships. It will require perseverance. But most importantly, it requires a change in focus. The focus that I want to see is the primacy of fairness, is a question of justice in equity in how we reach global maternal, newborn, and child survival targets. And I want to close with a statement of fairness that still rings as true as it did over 50 years ago. If a free society cannot help the many who are poor, it cannot save the few who are rich. Thank you very much for your attention.